This is Pat Iyer with Legal Nurse Podcast. And today I'm going to introduce to you a nurse who is a clinician and former associate faculty member of the McLean Center for Clinical Medical Ethics at the University of Chicago. And she did a post-doctorate in medical ethics at the University of Chicago. Camille provides some assistance to healthcare providers who struggle with some of the ethical issues that affect patient care. As we get involved in cases as legal nurse consultants, sometimes we see medical records that indicate that an ethics consult was called. Sometimes we see in progress notes clear struggles about some of the ethical issues that are raised by the care of patients. And I thought it would be great for you to hear a little bit of a different approach to this topic and how medical ethics impact legal issues and how they intertwine. Camille, welcome to the show.
Thank you. Thank you for having me.
Let's start and take a step back. We're going to look at the big picture, first of all, and say,
Sure.
Can you tell us, Camille, what is the difference between law and ethics when it comes to objectivity?
Sure. Both have objective criteria to be met and to resolve any problems or dilemmas. But the problem is that with clinical medical ethics, the objective principles are not known or valued as much as the laws. And that's mainly, at least from what I hear, is because ethical consequences for noncompliance with ethics are not as severe as the legal consequences. I mean, obviously, you know that if you don't obey the law, the consequences are pretty severe. You can go to jail, you can be, you have to go to court, where it's not that way with ethics. But they both have objective criteria to meet.
And I know that we've got varying degrees of acknowledgement about the importance of ethics within our healthcare system. The Joint Commission does accreditation or provides accreditation at a fee for hospitals, many outpatient centers, many other sites are accredited by Joint Commission.
Right.
And there are a couple of other big accrediting agencies in the United States, but Joint Commission is probably the best known
Right.
and I think most firmly entrenched system. And they have a requirement for an ethics commission. Can you tell us a little bit about what that requirement is? What does it entail?
Yeah, and that's a good question because the Joint Commission only mandates a mechanism to resolve ethical conflicts to be in place, but is silent as to the qualifications of ethics committee members, which is really interesting. They do have a formally published code of conduct that covers a lot of areas, but they don't have a mechanism to resolve ethical conflicts to be in place. So that's part of the problem. The American Hospital Association published a handbook for hospital ethics committees in 1986, and that identified some primary functions for ethics committee, but there's no standardized requirements at this time for ethics committee members, which is interesting, yeah. Which is part of the confusion.
So I'm envisioning somebody sitting in an administrative office somewhere in a hospital saying, all right, well, let's appoint the head of OB to the ethics committee and the intensivist and the social worker and a nursing director. Is it a random assignment? Is there any kind of preparation, or are there any qualifications that make a person ideally suited to be part of an ethics committee?
Yeah, no, that's a good question. And the answer to that is there's no formal preparation or orientation. And it's different for each hospital committee. There's no standard requirements for the choice of team members or their orientation. Which is interesting because one of the things that I did, and I don't know if it was on my bio, but I was hired by hospitals to educate their ethics committees because their ethics committee members did not have any background. So it was all subjective as to what their recommendations were.
Mm.
Yeah.
Have you ever been involved in a situation where the background of the ethics committee members was an important factor in a case?
Mm-hmm. Yeah. And I get called for this several times. So I'll give you an example. I was consulted by a legal nurse consultant who was experiencing a dilemma with a case he was reviewing. He didn't feel comfortable with the way the family spoke for the continuation of life support for their family member who was a patient. And he said the ethics committee was consulted by the healthcare team who disagreed with the family's request to continue life support, but that the ethics committee didn't give a reasonable decision as to why or what their decision was or why they recommended what they did. So as a result of their ethics recommendation, the patient was removed from life support. And now the family is suing the healthcare team and hospital for killing their family member. And that's the case that this legal nurse consulting was reviewing. And so he wanted to know how, what else he needed to know. If the ethics committee said it was okay to remove this patient from life support, then it was his understanding that that was the end of the line, that there was nothing else. And this will go to my, feeling of the gut feelings, how you just get a gut feeling that something isn't right. So my response, which is a typical good response from an ethicist, is more questions, which is sometimes frustrating, but you need to know more. My response included many questions, including what were the documented medical implications for removing life support, if the patient had no decision-making capacity, who determined the decision maker? What was or would be the patient's quality of life now and or later? Was the education and experience qualifications, what were they of the committee members? Other questions, the specific information they were given that led them to their recommendation and who gave them that information. The qualifications of the persons who gave them the information and what information was accurate and according to who. So there was a lot more questions that generated, which were just meant to be surface. But once I started helping this legal nurse consultant dig deeper into the qualifications of the ethics committee, it opened up a lot more information for him. And that's just one example.
And the question that you didn't bring up that came to my mind was, is there any way to determine the wishes of the family member prior to going on life support? Was there any advanced directives or conversations that were documented, or?
Well, that's what I wanted to know. I
didn't resuscitate
details, right? Who was the decision maker,
mm-hmm.
and who gave them that decision, and how were they making those decisions? Were they making it based on what they wanted or what the patient would have wanted? And how do they know that? And what evidence do we have for that information? And did the ethics committee, were they educated enough to know how to flush that information out and ask the right questions to get to that?
Yeah, that's a critical issue, a critical dilemma that I'm sure comes up in critical care units on a fairly frequent basis.
Yeah.
And when you think about if you have to weigh the patient's wishes and the family wishes, I know that there are some healthcare providers who will weigh the family wishes because the patient's not going to get off the ventilator and sue them for keeping their life going, right. But the family member could go after them.
Absolutely. Absolutely. And that's the fear of patients. That's the fear of patients. And as an ethicist, we really do intervene a lot, especially when there's disagreements between a patient or a family member and the rest of their family, and pull them together. And we're educated how to mediate those kinds of meetings, especially when there's such strong feelings one way or the other on each side. And then you throw in there the healthcare team who has their own feelings and their own reasons for wanting to do one or the other. And it gets complicated sometimes. Yeah.
You make me remember a case that I worked on to summarize records to find out if a woman had any pain and suffering after being hit by a car.
Exactly. Yeah.
And her family insisted that she be kept on life support because they had a hope that she would recover. And the medical record was full of notes written by physicians about attempts to explain to the family that there was no hope of any return to any quality of life based on the head injuries that this woman sustained. And there were several of those conversations she lived for about 2 weeks before she died. And ultimately, it's been a few years since I did that, but I think ultimately she died on her own without there needing to be an official turning off of the ventilator.
That's
very difficult.
Yep, and that's good. I mean, then that is, helpful, but that doesn't always happen.
No.
And we've had patients who've been on life support indefinitely and suffering terribly. Yeah.
And then the healthcare system, at least in the United States, starts saying, well, wait a minute, it's costing so many thousands of dollars a day. I just saw a bill, Camille. We'll come back to the questions in a minute, but I just saw a bill for somebody who is in a long-term acute care hospital in 2018. And the charge was $8,300 a day. And he was there for about 5 weeks. That was just for the room. That wasn't any of the therapies and the oxygen and the medications. It was $400,000 for him to be in this facility for 5 weeks.
Yeah, and that's another problem with the healthcare system right now. And a lot of the hospitals are trying to cut costs by saving money up front, but not realizing that by sending patients home too early, by having the cost of care so high, patients are either not coming in for preventive care because they can't afford anything, or they're let home so early when they're not ready to go home. They're not equipped to go home. And then they come back in 3 or 4 days in the emergency room, which is costing the hospital more money than it would have let the patient stay for 1 or 2 days longer. So the whole system has a lot of breakdowns that are really costing healthcare. They're raising the cost of healthcare rather than trying to minimize it, which they're trying to do. They're going at it the wrong way.
Well, we as nurses look at this one way. The people who are in the finance department are looking at these issues a different way.
Yes.
The physicians are looking at it a third way. As we focus on ethics, how have you experienced the difference between nursing ethics and physician ethics?
Sure. The code of ethics for all disciplines, whether it's physicians, nurses, social workers, therapists, they have their own code of ethics, and that each code of ethics is specific to their practice. Okay, so the nursing ethics is, what do I need to do as a nurse to be safe and to do my job the best? The same thing for physicians and social workers. So everybody has their own code of ethics that tell them the standard of what they need to practice in order to do their job. Clinical medical ethics, on the other hand, is newer. And what that does, and that's what I am, is a clinical medical ethicist, is that we look at the center of all of that. It's what everybody's job is, working around the patient. So we take everybody's standard of care and code of ethics of how they should practice their position in order to bring that to the team so that the patient gets the benefit of all of the team members.
Mm-hmm.
And that's the difference. Does that make sense? Yeah.
It does. Let's think about the role of the ethicist, because you're in a unique space. You're occupying very specific territory. And I would wager that many people who watch this podcast or listen to it will have never met an ethicist. Perhaps the closest they have come to, if they're legal nurse consultants, is reading medical records that state that there was an ethics committee involved. Right. And as we've just talked about, there's no standardized training for members of an ethics committee. So those individuals may be faced with some terribly challenging dilemmas and not have the training that you've gone through. You have a post-doctoral training in this topic. Tell us about what an ethicist does. What are the pieces where that person interfaces with the healthcare system? Before we continue with the show, I'd like to share this special announcement with you. Some of my coaching clients blame their difficulties on lack of space or problematic software. I've had to deal with those kinds of problems too, but I've come to realize that my clients and I were overlooking one big problem. The problem is one that we can change. It's us. Ask yourself these questions. Are your habits making things more complicated than necessary? Do you wait until the last minute to have others, especially ones who are paid weekly, do essential tasks? Is there poor engagement with your clients through email or phone calls? Do you push things like returning calls and sending emails off until the last minute? Do you fill in the blank, which causes undue stress on others or yourself? How many emails are piling up in your inbox? Okay, I won't tell you my number. Whatever your form of self-sabotage looks like, call it by its proper name and create a plan to stop it in its tracks. Then make a plan to cut it out of your life completely. Accountability for this is huge. This business tip comes from 21 Tips to Running Your Business Efficiently, How to Excel. Order it at lnc.tips/creating series. Now let's return to the show.
Sure. The job of a clinical medical ethicist, we're educated on how to obtain and incorporate the medical implications, patient preferences, quality of life, and other contextual features into their recommendations that are specifically and objectively individualized and patient-centered around specific objective standard medical ethical principles. So that's what we learn as ethicists, is how do we take the principles and make them apply to these situations that are causing the dilemma so that we can come up with the best. It's not always the only solution, but the best solution around the patient's wishes. Clinical ethics consults in the United States typically require an individual case consultation. So if there's in response to requests from clinicians or occasionally from patients and their families, and patients and families don't always know that they too have access to an ethics consultation. They provide ethical input into hospital policies and developing guidelines and education of health professionals within the institution. So there's ongoing ethics education. So in practice, case consultation is more likely to be carried out by an individual ethicist, or now increasingly by small multidisciplinary teams, which may include ethics committee members as part of that team.
And I think about the range of questions that could come in front of an ethics committee or an ethicist. I just remembered another case that I worked on involving a child who was born through a ruptured uterus. The woman had gone through an attempt to have a vaginal delivery after having had a prior C-section, and her uterus ruptured, and this child was born alive, but experienced anoxic brain damage as a result of being pushed out of the uterus in a non-standard way away from the placenta. And he lived for 2 years in a children's hospital, where the staff were meeting with the family, again, like the prior description that I gave you of an adult woman who was hit by a car. This was a child who was, it sounds terrible what I'm going to say, but he was consuming medical resources for 2 years, just gaining weight, but ventilator dependent, no interaction, no nothing. As we say in New Jersey, there was nothing coming back. And the staff kept periodically talking to the family, working towards a decision about what to do with this child. Ultimately, they worked with the parents, who got divorced over the trauma associated with this experience, and got him home with a private duty aide. He was so fragile that he lasted for 12 hours at home. The private duty nurses and aides were not equipped to be critical care nurses because of the instability. He had autonomic storming, so his vital signs were extremely labile, and he ended up dying after months of effort and lots of discussions on the ethics of, is this providing any quality of life? And the child had no quality of life, and the parents got destroyed. Their relationship got destroyed by all of this. If this kind of a dilemma came in front of an ethicist, I know I've heard you use the expression of trust your gut instinct. Can you tell us how that would apply to an ethical dilemma of the kind that I've just described?
No, and that's really a good question, because it's always varied. Okay. So when you as a medical provider, as a clinician, whether you're a nurse or a social worker or whoever is part of the team, and you have a gut feeling, and this happens all the time. It happens every day with every patient, and we just sometimes don't even raise it in our own mind. I just don't think something's right here. Something's not right. We're missing something. We're not doing something correctly, or we could be doing something more, or I just don't feel comfortable with what we're doing. Typically, and I found this in my practice over 10, 20 years, that typically there's this hierarchical approach to raising those feelings without having the evidence, without even being able to articulate it, and feeling that it's just going to be ignored, or that you're going to make a fool of yourself because you don't even know what you're talking about. And so this hierarchy of raising questions is what typically pushes a lot of those feelings that are valuable. Because if you're feeling it, then where's that coming from? And then it's our job to flush it out, to figure out where that's coming from so that we could address it. And I remember, clinicians saying, if I'm crazy and this isn't anything, tell me. I'd rather know based on the evidence than to think that I'm missing something and that I'm not raising it. So that's another role when I was talking about the role of a clinical ethicist. It's a place for clinicians to go to say, I know this isn't a question and I know this might not have any value to it, but I just got a feeling that this isn't right. How do I flush this out? And typically what an ethicist will do is what I did with the legal nurse consultant is ask questions that are pointed enough to give the clinician something to get more information about. And then to take that information and put it into a multidisciplinary team meeting so that we could all put our own perspective on what's going on and then raise the right questions. When I started this at a major medical center, the physicians were very much against this. They just didn't think, they thought it was a waste of time. They thought they listened to nurses and social workers and other team members and thought that it was a waste of time and that they weren't willing to do this. But once the institution supported this type of mediation, just starting with the healthcare team members, it was so valued that even the physicians were calling ethics consultations because they wanted to hear what everybody else's gut feeling was so that they knew the kinds of issues that were buried and not raised to a level of understanding. And that what your specialty isn't what my specialty is. So we have to talk about what we each know in order to come to another level, another dimension of understanding to help this patient. So that's what I meant about gut feeling, is that if you're feeling a gut feeling that something isn't right or that you just don't know what it is that you're uncomfortable with, that's the definition of a dilemma. Right? You're between a rock and a hard place. You're not sure where to go. You're not sure what it is. That's the time to call an ethics consult. And an ethics consultant will not listen to what you say and give you an answer. That's not their job. Our job is to listen to what your gut feeling is and what your discomfort is, and then give you more questions to make you think of what it is that we need in order to get to an answer.
It reminds me of the definition and the difference between coaching and consulting, where consulting tends to give the answers and coaches tend to draw out the answers.
Exactly. So it is more coaching than it is consulting, to a level that really, I do it myself, and I'm an ethicist, and I've gone to other ethicists and say, okay, what am I missing? Something isn't right. We do that as professionals. It's going to the right resources that will flesh out the right information. And the other thing I found is when a group of a certain discipline clinician, they'll go to each other and it becomes small talk, or it'll become what's the word I want? Where they'll just talk behind everybody's back, but they're not getting the right resources to be productive. So it becomes more like gossip is the word I was looking for. It becomes more like, this patient is crazy, or they're not listening to me, or they're hard, they're not compliant, and I'm trying everything I could. And they're going back and forth with each other, their friends, their colleagues, but it's not going anywhere, number one, because everybody's agreeing with everybody else. And number two, there isn't a source of first of all, being objective, and then second of all, feeling comfortable enough to challenge those feelings so that we could bring it to another level. So when you feel that gut feeling, you have to also be open to the fact that somebody might know where to go with this better than you do. And just because you feel it doesn't mean it's right, or that you're right, or that it's wrong. So it's being open enough to be humble enough to take it to the right people, not make it a gossip,
Mm-hmm.
a gossip topic, because that not only is going to not go anywhere and be non-productive, but it's also hurting everybody that's involved without even knowing it, including the person that's doing the gossiping, because they're just as frustrated it's not getting resolved. But they're just feeling confirmed, right? It's like, okay, you agree with me that this patient is crazy? Okay, good. That's what I need right now. But it doesn't go the next step to say, yes, this person is crazy, but let's figure out why so that you could be the one to help them.
Right.
So it's empowering that patient. That's our job. I mean, empowering that clinician. I'm sorry, that's our job.
Camille, you may be surprised to know we're at the end of our time, and I feel like we've just gotten the top layer off this topic. How can our listener who's listening to this on our audio channels or our viewer watching it on Legal Nurse Business YouTube channel, how can that person find out more about you and the services you offer?
It's a good question because it's a hard answer, I guess. There, there's a lot of resources out there, and there's a lot of people that are educated in medical ethics. Somebody brought my attention to this, and there is. Let me just read this. It's a link to that's called. There is an expertise finder network. It's called an expertise finder network, which lists 34 experts in medical ethics nationwide. The only thing that, and I think that's a good place to start, is to find a place that's a reputable organization that you know of, the American Medical Association, the American Hospital Association, that are reputable, and start, or a link like this that gives these backgrounds, pictures of these ethicists, and to start there. But the other thing that I would warn everyone who's doing this kind of research, because it could be so subjective, is to really make sure that whoever you consult with, you look into their background. Make sure they were educated at a reputable ethics education program, okay? To make sure that they have an ethics background, that they have a degree in clinical medical ethics, that they're professionally and officially recognized with usually a post-doctorate certification. And then also to look for evidence of their medical experience and their role as a medical ethics consultant. And what is their background? Have they done ethics consultations? So it's finding them, and then it's narrowing it down to find out about each one of them. And that's the best I can do right now, because there isn't a lot of them, and a lot of clinical medical ethics aren't just practicing and teaching, and this is what I'm working on right now, aren't just educating and teaching medical ethics. They alone are integrating ethics into their own medical practice, but they're not teaching what they learned because that wasn't their priority. So it's not always their priority. But if it's the priority of an ethicist, then you have to make sure that they also have the background and the evidence.
If they wanted to reach you specifically, what would be the best way for them to do that?
Sure. I have a website, actually, and our website is Healthcare Competency Program Specialists, plural, LLC. And there's all my information on there about me. Click on the tabs at the top, and there's also a place there to leave us a email. I will also give you my personal email address, which will make me respond directly and quicker.
Mhm.
And the email address is all one word, lowercase, CREN as in Nancy, ELLA at att.net. And that's my personal email address, and I will always answer it as quickly as I can. I get hundreds a day, but I will answer all of them. Yeah, and the other thing, in order to understand a little more about the ethics and what to deal with, if you go to my website, at the top there's a tab. And if your viewers would click on, if legal nurse consultants would click on the tab that says, what would you do? We post vignettes of these situations that we all deal with every day. And it's followed by specific questions. Doesn't give the answers, because what we want you to do is think about it in regards to the ethical implications that you think would get to those answers. And if any legal nurse consultant is doing that just to train themselves on how to look for information, please feel free to reach out to me to talk about any of those cases further.
Thank you, Camille. I appreciate the time that you spent opening up a little corner of your world for us to think about how ethics impacts us. We've talked about clinical ethics and gave a couple of stories of issues related to prolonging life support. There are ethics that affect us as business owners, and business ethics can pose dilemmas for us working with attorneys, our clients.
Yep.
There are ethical issues that affect us as healthcare providers that might relate to decisions of our employers.
Yes.
In corners, not providing enough staffing, not providing enough food and support to vulnerable people in an effort to increase profit in a facility, for example. Outright fraud and fraudulent decisions that have ethical implications. So we've looked at one little piece of this in the last 30 minutes, and certainly much bigger issues that affect all of us as business owners, as healthcare providers, as legal nurse consultants. Camille has stressed.
As a legal nurse consultant, I have experience, as you do, in all those areas, which is why I'm doing what I'm doing, to integrate it. When I first started as a legal nurse consultant, I was already an ethicist, and I tried to present that to attorneys and to legal nurse consultants that was just starting. And there was a real resistance, thinking that there was no overlap. But once I was able to get in the door and do my conferences, it was really relevant that all of those pieces, the business, the working with attorneys, working with administrators who are telling clinicians what to do, and they don't even have any medical background, and yet they're telling me how to do my job, kind of thing, right? So our job is to integrate all of that so that those issues are flushed out, so that we can start resolving them. And it might not be one answer fits all, but it might better be what's more specific to what you're dealing with in those situations, so that we can all, our responsibility as a nurse, that is always going to be based on nursing code of ethics and based on medical ethics, the patient first. That's why you're being hired by the attorney. And if there's a disagreement or they don't want you to do that, that could be a problem. But anyway, those are the subtle things. And I'll shut up.
Thank you.
Go on all day because it's so
I
much,
know,
so.
I know. It's like
you.
pulling back layers on this topic. Thank you to you, Camille, for
Thank you so
being
much.
a guest on the show. Thank you to you who's watching this show or listening to it. Be sure to go to podcast.legalnursebusiness.com. You can sign up for the transcripts of our podcast. There's no charge for the transcripts. And we are also now offering an updated version of podcast bundles. There's also no charge for the bundles. You can pick the top 4 podcasts out of a total of 6 different categories. Those are top podcasts because they got the highest number of downloads, and we poured through the data and assembled them into bundles so that you can get the best of the best on a variety of subjects within Legal Nurse Podcast. And be sure to come back next week for a new show.
Can I just tell you one more thing? Based on everything I talked about today, I do have references. I mean, obviously there's evidence behind everything I've said. And if it's needed or if it's requested, please let me know and I'll be happy to give you my references.
Okay.
So it's thank you so much. Bye, everybody. And I appreciate it.
Thank you. And be sure to come back next week. New show, new guest.
I will. Great. Thank you.
Hi, coming up next, we have Jean Cooper, who has presented in a prior podcast the story of a woman who was accused of killing her 10-month-old child. Jean has a strong background working on criminal defense cases as a legal nurse consultant and shared in this podcast, part 2, some of the more detailed information about how a legal nurse consultant can be effective in helping on criminal defense cases. Jean, I know that our viewer is going to want to know, what are some of the key points that you went through in this podcast?
Thank you, Pat. We discussed the biases that impact the case from the very beginning, starting with law enforcement and the emergency room providers, doctors and nurses and social workers, and nurses and doctors in acute care with a critical care setting. And also, if the child dies, the medical examiner's office. All along the way, there are biases that impact the outcome of the case. And we also talked about the conditions that present initially maybe looking like child abuse, but what other conditions could present that way. Someone who was very sick with pneumonia and stops breathing could suddenly stop breathing. Doesn't mean that they have head trauma or something else. It was just a lack of oxygen. Someone who has pneumonia may develop sepsis from the overwhelming infection that just increased, and that would cause them to stop breathing. They could also have bruising all over their bodies that may be due to medical interventions, starting with the emergency medical system. Even just touching her, if she is so ill, might cause bruises. Or think about how brutal CPR is, how difficult starting an IV on a child, so perhaps they're putting access into the bone. Well, that's pretty brutal and can cause bruising. Just holding a mask on someone's face to breathe for them with the valve mask, bagging them, all of that stuff all of those interventions cause bruising that someone down the line, a healthcare provider down the line, could perhaps suppose that it was from intentional trauma as opposed to something else. So the role of a legal nurse consultant is to review medical records from start to finish and even before the beginning, to determine if there is an alternative cause for what the healthcare team is finding as abuse. Not all retinal hemorrhages are caused by intentional shaking of a child or head non-accidental head trauma. So we support the legal team all the way through with looking at issues, defining, explaining, and analyzing issues with the legal team and their medical experts.
Well, you can see that Jean covered a lot of information in her podcast, and you want to be sure to listen to this podcast to get more insight on how a legal nurse consultant's knowledge can be so essential for the legal team. Be sure to get Jean Cooper's podcast, and I will see you on the next show.
Thank you.